Happy Tuesday.
Happy Tuesday to everybody. Really excited to discuss another case with Ravi. You all are new around here. Welcome to Virtual Morning Report. We do this every day on this platform. People tune in from all over the world for cases here, and we're going to discuss a case today with Kashayar. Actually, Kashayar, do you want to say hey?
Hi everyone, I'm Hasher, medical student from Iran. Very excited to be here.
Thanks for being here. What have you been up to?
I'm in my peds rotation right now, and I actually brought a pediatrics case. So,
Oh man, Ravi, are you ready for peds? I don't know
You,
if I
you know what? Robbie's on the call too. This most certainly beats the case of the cat with a hematological problem.
Wait, I don't know if I saw that one.
Yeah, yeah.
Oh my
Robbie
God.
could probably attest to that one. That was like, that's something like cat. But you know, it's interesting. The hematological physiology is pretty similar, except, yeah, of course, the lab value is going to be different. But I still remember that. I was like, that was who presented that case. I'm trying to remember. Ariel, who was a veterinary student, and
Wow,
that was quite different. Yeah,
that's so cool. Well, I'm excited. I'll definitely be leaning on a lot of people in the chat for this one, but shall we get started?
let's go.
All right.
all right, amazing. So, this is the story of a 2.5-year-old boy who presented with skin lesions around his mouth. The lesions started as few macular lesions around the mouth and then further spread to nose, and they increased in number and size. The father of the child has seen yellowish crusts on the lesions, but none can be appreciated now. I'm gonna stop there.
You want to start, Andrew, with that aliquot?
Sure. This is not at all an area of strength of mine, so I'm going to be soliciting a lot of help from the chat on this one. I don't A, see a lot of rashes in adult medicine to begin with, and then B, this is pediatrics, so my N is very small for these sorts of reps. I mean, I'm going back like 6 years to my peds rotation now. This I think we can categorize right now as more of like a focal not even infection, but like a focal rash. So I think that's one good step we can take to sort of categorize what's going on here in terms of making progress. It seems everything's kind of on the face right now. And when I see that, I think of infections like bacteria, fungi, yeast, those sorts of processes, since things are still local at this time. But we're also going to be getting, I imagine, like a vaccination history from this infant. I can't even like age stratify this patient correctly, but I'm sure we'll get a vaccination history. We're gonna need that to see if this process becomes more diffuse. How helpful that will be, because when things become more diffuse, then we're suddenly kind of in the world of viruses. But that's all I got, Ravi. What about you?
Yeah, nothing's more, I guess, astounding than having or starting with a dermatological complaint. But two things come to mind. I mean, first, so if I am limited knowledge wise, say it's not something that I do day in, day out, unless I'm maybe at an urgent care center or maybe in a peds emergency room, unless it's something that's very systemic and could potentially be hazardous, bringing the patient to the emergency room. But if we just kind of like break it down, take a deep breath, break it down, the location of the rash and the rash itself. So when we look at the differential diagnosis for rash, there's a type 1 sort of thinking with this, with a crust. I guess the crusting could be considered like impetigo. So impetigo, is it commonly around the mouth? I doubt, but that's something that comes to mind. Um, Infections is one cause, but then if you look at another subset, maybe allergic and immunological causes. So eczema can be a cause, contact dermatitis could be a cause. Then comes viruses that could cause. We're not getting vesicular. So this, I think, it was a macular kind of a rash. But if there's some vesicles, you could think about dermatitis. You could think about also HSV around the mouth as well. And then you could get other things like pityriasis or lichen planus. So with all these different kind of rashes, which one fits this? I'm not sure. But my second mode of thinking with such a presentation is the skin, disease of the skin could be a reflection of what's going on inside the body. So could this be something systemic with the patient? So we're going to definitely be looking elsewhere internally if there is a autoimmune cause of this rash. Is there other manifestations such as the joints or other organs? Could there also be manifestations in the blood chemistry, CBC, or anything like that? Is there some maybe hematological disorder going on as well? Kind of early in the process to kind of hypothesize on that, but just defining the rash, I'd be worried about, is this something that could be allergic, immunologic? Could this be autoimmune? Could this be infection, bacterial, viral? I forgot, maybe fungal. You could get sort of dermatophytosis around the mouth, though unusual. And then the contact dermatitis is interesting. I would also like to get a history like what's being used around the mouth as well, cleaners, skin products, toothbrush, toothpaste. Is it just around the mouth, or are we going to get more elaboration on this complaint with a physical exam? Anything else, Andrew, before we swing the mic back to Bashir?
No, I think that's a really impressive framework in terms of soliciting more symptoms and how to kind of approach labs to look for like imprints of systemic disease, like you were saying. That's great. All right, what do you got, Kasher?
Amazing discussion and amazing thoughts in the chat. So, on initial encounter with a patient, you see that a child is extremely irritable and agitated, but he is not in an acute distress. He seems well perfused without immediate signs of cyanosis and hypoxia. There is no past medical or surgical history and no history of prior hospitalization. When he was first seen by his primary care provider outside the center we are in, he was started on cetirizine and acetaminophen and has been using them for the past 3 days, during which time his appetite has been poor and he has been in pain, agitated, and irritable. On first assessment, you see that the lesions have spread to the neck, all around the face, hands, and the diaper area, and around the eyes, showing bullous lesions with exfoliation of skin at places with a positive Nikolsky sign. No lesions can be appreciated inside the mouth or other mucosal areas. He was born with C-section at 42 weeks, weighing 3.5 kilograms. Right now, he weighs 12 kilograms with a height of 87 centimeters, which is normal according to the charts. His vaccination history is up to date with the current national program, and he currently lives in an urban environment without a history of hospital or sick exposure recently. If you need data on the vaccination history, more detailed data on it, I can provide it, but he's up to date on his vaccinations.
Well, it's interesting. I'll kind of start with a few things here. So when Kashiar mentioned bullous lesions, especially with excoriation, so this is a bit more complex than maybe some of those superficial infections of the epidermis. With the bullous lesions, you can't help but think type 1 maybe is this, and we kind of hypothesized about autoimmune conditions. Could this be sort of a bullous pemphigoid, pemphigus vulgaris? Is this something along those lines? You can also get something more sinister like Stevens-Johnson's, but that you would look, somebody had mentioned, is there mucosal involvement? Somebody in the chat also mentioned, I thought that was a great point. So there's no involvement of the internal mucosa membrane. So we can sort of take a deep breath and be relaxed in that. If you have a patient like that, that's somebody that you need to get to a burn unit. If it's the onslaught of SJS, TEN, and it could spread further because this spread from the mouth to the neck as well. So at this point, there's no internal involvement. You also want to do a check of the urethral mucosa, the anorectal mucosa as well, just to make sure if there's any involvement as well. But at this point, erythema multiforme, is this a bullous sort of a variant? I'm not sure at this point, but this is concerning, especially when the bullae, and you get that Nikolsky sign. So that definitely is some impending excoriation of the skin from these lesions. Anything you think, Andrew? There was another thought that kind of got my attention just going back. There was maybe scalded skin syndrome came up quite a bit times. Pemphigus was being mentioned as well. Chickenpox more vesicular, and the impetigo again with the crusting. So that could be non-specific, but the bullous lesions are very concerning. And I think hand-foot-mouth syndrome is something in kids as well. I doubt that, though you don't get Nikolsky sign with that, but that Coxsackie virus could be something with vesicular lesions as well that children get at this age. Anything comes to mind, Andrew?
Yeah, I think, initially it seemed like this was going to be something more focal and simple on the face, but now that it's more widespread, and I don't know how much a red flag bulla in itself is, but the fact that this is widespread bulla does seem like a red flag to me. So yeah, definitely thinking something systemic here, so like systemic infection versus systemic autoimmune syndrome. I don't know about the scalded skin syndrome. It's curious. It sounds like it's a complication of like a simple staph infection. So maybe what we saw on the face is what's triggering the rest. Someone in the chat, please let me know if that's kind of what your thinking is. But yeah, I think everything you hit on, Ravi, are the most important kind of no miss diseases, given kind of the diffuse blistering nature of the disease. And I don't know how early the autoimmune blistering conditions present, but I want to say that that is something that's described as one of those like biphasic diseases. So yeah, that would be crazy. I imagine we need to send, I don't know if we could do, if this staph scalded skin syndrome is like related to group A strep, if we want to send like a strep test of the throat, and that would be supportive of this skin syndrome. Someone let me know if that's what we would be doing. I saw Elena in the chat mention mycoplasma, which I know has a lot of reactive immunologic things like erythema multiforme, and I believe there can be a bullous form of erythema multiforme. So mycoplasma pneumonia is probably very fair to send for a patient like this. And that would be like a blood test. You could do serologies, IgM, IgG for that. I don't know about viral testing otherwise, since we have this person up to date. And I see Hans in the chat mentioning biopsy. I think, if we send all the infectious studies and everything pans out negative, and we're thinking autoimmune blistering conditions, that is kind of where we end up. But yeah, I think interesting pivots, no mucosal involvement, like you said. And I'll just say, someone in the chat earlier, I think, was mentioning, how worried are we about this patient, this very, very young patient? The patient seems like they're in distress. Like, I'm not a pediatrician, but it sounds like they're not able to really like take in PO anymore, and what's going on is very, very painful. So probably should admit this patient to the hospital and do a more expedited workup for them. Yeah, yes, exactly. But that's all I got.
Yeah, just to add to that, the chat started exploring this territory of drug-related conditions. So you do have these conditions which are triggered by medications. So they could be antibiotics. So Bactrim's notorious for this sort of generalized maculopapular morbilliform rash, but again, it doesn't involve the mucosa, and it usually happens like 4 to 5 days in, and tends to go through this initially this erythematic stage, and then you get this desquamation phase, but no bullous formation. And then somebody also mentioned DRESS or DAHS, which tends to happen 2 to 4 weeks after. Usually, like anti-epileptics can potentially cause those. Antibiotics could potentially also as well. But you do get internal mucosal involvement as well. And then you get the SJS and 10, which we're not at, but it wouldn't be surprising that that can form like 2 to 4 weeks, stress 3 to 4 weeks, maybe. I've even heard 2 to 4 weeks, but takes a long time. But with this patient, I think we're probably not there. But yeah, I like this mycoplasma. Okay, with children, Coxsackie, this herpagina you get, where you get lesions in the tonsil and the palate, I think that can also discriminate. That is an interesting theory as well. But I'm interested to see the vital signs, see if there is a rip-roaring fever, if there's signs of toxicity. Like you mentioned, is it a patient we need to get to, if it's one of those more nefarious skin disorders, need to get to a burn unit and get appropriate treatment. So let's see what Cashier has in store for us. Back to you.
I'm really loving this discussion. It's like I'm studying the fever and rash chapter again. So let me give you the vitals. He is feverish with a peak of 39 degrees during the course of his stay with us, which was 3 days. He is tachycardic with a blood pressure of 90/60, which was normal for his age range, with a respiratory rate of 33, again, normal for his age range. Uh, his exam generally showed that the child is in pain and irritable, but there is no acute respiratory distress or signs of poor perfusion. Other than the skin lesions around the eyes, the rest of his hint exam is normal. The ears look normal. His eyes, there's no conjunctivitis in the eyes. He is tachycardic, but without abnormal heart sounds and murmurs. His lungs are clear, no coughs or respiratory symptoms in general. His abdomen is non-tender and soft without complaint of abdominal pain. No history of change in bowel movements, no diarrhea or constipation. His neuro exam was normal. And his extremities and skin exam, I already discussed a lot of it in the first two aliquots. There is not much else to add here. And I'm just going to give you his hematologic labs and stop there. He had a white BC of 7.2, hemoglobin of 12.2, a platelet count of 233.
You want to start with this aliquot, Andrew?
Yeah, I don't have too much to say. Otherwise, I think all in our heads we were thinking this patient was going to be inflamed. You know, they have fever. They don't have a leukocytosis, interesting, and they don't have a thrombocytosis, indicating that this is an acute presentation, which aligns with what the history was given to us. And you know, we don't have any chemistries yet to definitively say that there isn't organ involvement with whatever is going on that would make us more worried about some sort of drug reaction, particularly DRESS or drug-induced hypersensitivity syndrome. Somebody mentioned that, but I think if I'm understanding the history correctly, this all started before the medications were given, and this would be too early for DRESS too, is the one thing. DRESS takes 2 to 8 weeks, I believe, to come out of the woodwork, because you need to develop this type 4 immune response to the initial culprit drug, which takes a while for those antibodies to form. So I think it's a little too early for DRESS, and I'm not sure that we're going to see organ involvement here. I'm just getting the flavor that this is really like a very inflammatory, just primary dermatologic syndrome, and it's going to be, it may actually end up being one of these autoimmune conditions, because I feel like the viruses often do leave in imprints in the liver, like in the form of hepatitis, or if things are really morbid, it can touch the CNS, like meningitis, encephalitis. So you know, neuro exam on a patient like this is probably a little bit more challenging, but it sounds like things are okay from that perspective. So yeah, I'm getting the sense that maybe the chemistries are going to come normal, and we're really going to have to focus on the skin and go for that skin biopsy if our initial kind of reactive infection screening, like this staph scalded skin syndrome, which I still don't know too much about, pans out to be negative. But what do you think, Ravi?
Yeah, I agree with you. There's nothing more surprising that we have from this aliquot. So I think I did want to see a differential for the white cell count. If there was more lymphocytosis, maybe that would be a signal for viral phenomena. But at this point, we're not even seeing. I guess the hemoglobin's normal for a child. So we're not even seeing anemia of chronic illness. So this likely has not been manifesting for a while. But chemistries, I'll be interested to see if there's anything there, any signal or anything that we could pivot on. But at this point, we're still in that domain of these lesions. They're in the around the mouth, the neck. Is it spreading more? Is there more development in this case to then become one of those more sinister kind of causes that we'd explored? But at this point, there's nothing that, I mean, the whole landscape of viral diseases and some of the bacterial diseases you mentioned. Again, I'm interested in going from herpes labialis, but it wouldn't be this diffuse, to Coxsackie, to could CMV? No, probably not. HIV could manifest, but in a child at this point, you just never know. Measles, we're seeing a recurrence in measles. I just wonder. Yeah, and this child is in Iran, so this is not the United States. So we also have to wonder if the child got all their shots. So, you know, here we're pretty stringent, no shots, no school. So a child here in the United States can't attend school until they get all their shots. So I'm just wondering if there is a lapse in shots, and then we're dealing with one of the illnesses that we commonly don't see here. Any other thoughts, Andrew?
No.
So measles, mumps, rubella, so on, all of that we have to wonder about. And then chickenpox. I mean, it's not diffuse yet, but something to think about. But again, those don't have the kind of bullous lesions like this. You could always have variants. I'm just imagining going back to the pemphigus. We always wonder. I did have a patient with pemphigus recently, which was very exciting, but it won't manifest in this manner, though. But the Mikulski sign, we always, system one thinking for step one, we always think about that. But yeah, the right now it's very nebulous at this point because I don't have that much knowledge in this domain. But I'm kind of excited to see what Kashiar has in store for us. Back to you, Kashiar.
So just a heads up, I'm just gonna give some labs here, and this is going to be my last aliquot. I gathered the information for the case after I changed my rotation. So one thing that was interesting to me was that not a lot of testing was done. So I'm just gonna give you this data and you can discuss. His sodium was 136. His potassium was 3.9. ESR of 17, CRP of 6, BUN 12.9, creatinine of 0.6, glucose of 197, calcium of 9.8, magnesium of 2.0, AST 53, ALT 25, and phosphatase of 391.
So sort of jumping on board with this new data here, I think AST is a little elevated, if that's correct. Is that right, Kashiar? AST and the ALT is a little elevated too.
Just a little.
Just a little. Okay. So we were looking for signs of internalization of this rash. Is this rash something that's going inside, or is the inside manifesting outside on the skin? What was the famous saying? The skin is a reflection of internal disease. So at this point, there's nothing massive. There's just a little bit of AST elevation here. But does that mean the liver is involved? So once we see the AST elevated, we want to look for other enzymes that may signal hepatobiliary disease. So ALP is actually elevated, right? I think ALP is elevated, 391 also. So ALP is elevated, but we also have to be cautious if ALP is coming from somewhere else. So in a growing child, ALP can be elevated as they grow, alkaline phosphatase, but not to this degree. So I think we can pair this up with the liver. Also be very cautious. AST could be coming from muscle rhabdomyolysis. It could be coming from hemolysis, but we're not sort of getting that flavor here. So we'll track back to our hypothesis of maybe hepatobiliary association. Bilirubin, we don't have that, but if that is elevated, that could also signal possible hemolysis versus, again, hepatobiliary disease. But then why would the liver or hepatobiliary system be manifesting with skin? Like PBC, if you have elevation in bilirubin, it could cause pruritus. So that could be one manifestation. You could have autoimmune disease, and that could cause also skin findings. I don't know if there is something that will cause it to this degree with bullous formation. But then again, viruses, infections can cause a little, like CMV can do it, EBV can do it. It can cause some mild hepatobiliary involvement as well. So I don't think this is a signal of severe hepatobiliary disease, but it could be just a manifestation of maybe what's causing the skin and maybe internal abnormalities, which could be a viral illness that we're dealing with. The rest, the chemistry is normal. The kidney's normal. So again, we were thinking about DRESS syndrome, something like that, but we're not. We're seeing a little liver enzyme elevation, but unlikely that at that point. Usually, patients will be very ill with DRESS syndrome and lymphadenopathy. Somebody mentioned in the chat that is also a very, very good sign in trying to decipher if this is drug-induced hypersensitivity syndrome. Eosinophilia. So what's interesting, DRESS used to be called like drug-related eosinophilia with systemic symptoms, but they took the eosinophilia out because you don't always have to have eosinophilia. I think 50% of patients may manifest with eosinophilia, so it's not a hallmark or pathognomonic feature of this condition. So DIHS is the new terminology, and so if there is eosinophilia, again going back to the differential for the CBC, that could be a clue that this is maybe this condition. Andrew, what do you think?
Yeah, just two questions for Kashar before the final diagnosis. Is this alkaline phosphatase high for the age of the patient?
From what I remember and what I know, it's not high. It wasn't high that we were concerned for it. Like it was relatively okay for the growth range he was in. We weren't too worried about, yeah,
Okay, that
alpha
makes
synthase.
that's very helpful. And then the bilirubin, if you have it, was that normal too?
We didn't test for bilirubin.
Okay, got it. Got it. Okay, that's really helpful because I would have been very surprised if the alkaline phosphatase was very high. If the alkaline phosphatase was very high out of proportion to the bilirubin, and there's no reason for a bony issue, because the other big reason you can have a very high alkaline phosphatase is bone, which we have no suspicion for that in a case like this. Like nobody's been talking about bone this entire time. So in that case, we would be thinking about the liver. And when you see an alkaline phosphatase from the liver that's very, very high out of proportion to a bilirubin, that makes you concerned that there's some sort of infiltrative process in the liver. And I wasn't expecting that. So that's why I wanted to clarify that here. And the degree of the transaminase elevation here is so minimal too. I really don't know if that's going to end up bearing fruit in terms of being it's really helpful in terms of, oh, there was a virus on board for this. But yeah, it sounds like we need a very broad differential for this, and we just need to send and test for all the things that we had mentioned and see how it pans out. I'm really not able to put my money down on any one thing here. Anybody else in the chat want any other final tests before the last aliquot or the final diagnosis?
I guess we'll go back to cashier.
So based on the history that we got from the patient and especially the yellow crust, our first and kind of most morbid diagnosis at that point was this staph scalded skin syndrome. And we started treatment based on that. And the patient got rapidly improved. And he was discharged on day 3 with antibiotics at home. And on a follow-up next week, he was looking very well. So while we didn't have confirmatory tests on whether this was actually the diagnosis, the response to treatments suggests very strongly that this was actually the diagnosis.
Cashier, that's so interesting. Yeah, it sounds like they were so confident in that diagnosis that they were able to treat for it. It sounds like they see this all the time and in kids, and it's curious. We never talk about this in adults. Is there a reason why we don't see this in adults? Can we see this in adults? Is it a different name in adults? It's just so interesting that this is like so well described in kids, but we never talk about this in adults. So you have me very curious.
From what I know, it's not even that common in children, but I think it has something to do with it being toxic induced, like the toxin pathophysiology in adults presents in a different manner.
I see. Okay. Well, certainly, toxic shock syndrome in adults is super, super scary, very high mortality. I don't know if that's the same case as in kids, because this child did better so quickly. And in adults, I've seen toxic shock syndrome from group-A strep before. In an adult, that patient died, and the mortality is extremely high. So I'm wondering if this patient got really, really lucky that you all treated them quickly, or if there's something about children's immune system, if their immune system is intact, that makes them a little bit like safer, have lower mortality if you treat it quickly. So yeah, very, very interesting. Rafi, what do you think?
Um, yeah, it was interesting. System one thinking, pretty much with the yellow cross was aligning us with this with the group A strep and Streptococcus aureus and scalded skin syndrome. But you know what's interesting? I forgot. It's been a while since I looked at the microbiology features of this condition, but I just pulled up my note on this. So the way it starts is exactly how Kashara had mentioned. So you get this fever, redness of the skin, and this erythema starts around the mouth. So that's a key feature one, right? So we started with the mouth. Within 24, 48 hours, you get large, flaccid bullae. Key feature number two. Key feature number three, Nikolsky sign, leading to raw, moist areas. And then key feature number four, I like this term key feature, so I mentioned it. So periorificial crusting. I mean, that pretty much is what this case is. So we don't see that. We always think about, toxic shock syndrome, right? Group A strep, staph, and nasal tampons and so on, and things like that could be a harbinger of this. But we don't really think about in children. Again, this is a little bit of a different case because we're dealing with a child, and usually this is seen in children, newborns, but we could see in adults that are immunocompromised. So something to think about that we could really learn from this case and maybe improve our illness script for this condition. So wonderful case. I mean, this is exactly described in the notes, but it's just I've never seen it before. And yeah, I think your team had a strong enough pretest probability to treat because it follows these features, and the treatment both diagnosed it and also treated the condition. So kudos to you. Wonderful presentation. Just love the case, and thank you for bringing it today.
Yeah, Ravi, I think just one other reflection, it makes me think of, people were talking about SJS. I wonder how the pathophysiology and also toxic epidermal necrolysis, if the pathophysiology of this condition that's presumably super antigen mediated and it's mediated by this toxin people are mentioning in the chat, if kind of that exogenous source that triggers this hyperactive immune system is at all overlapping that pathophys with SJS or TEN. Yeah, very, very curious. I'm going to do some reading after this for sure. But thank you, Kashar. Very, very interesting case.
I'm really happy you guys enjoyed it. This was a fantastic discussion. I learned so much just going through the different diagnoses. And yeah, the reason I actually brought the case was despite the incomplete confirmatory diagnosis, it presented very typically like the patient had read the textbooks. But yeah, thank you so much, everyone. This was great.
Awesome. Ibrahim, do you want to take us through the teaching points?
Yeah, absolutely. Thank you, Ravi, for the awesome discussion, and thank you, Andrew, as well. I think you guys like are internal medicine specialists at this point, but you tackled this as if you were actually dermatologists. So kudos to you, I guess. And thank you, Khashayar, for this case as well. So when it comes to rash in pediatric patients, there are multiple things that you need to think about in such patients. And the first and most important thing is the character of the rash itself, because the character can provide a great clue to what the underlying disease is. And so if you have crust, for example, in the rash itself, this could clue you into something like impetigo. Whereas if the rash is vesicular in its character, then you can think about something like dermatitis. And it could be contact dermatitis, or it could be autoimmune dermatitis due to any other cause. And then you can also think about the location itself, because the location can also pinpoint an underlying disease that is manifesting in that specific patient. And so if you see a rash on the face in a pediatric patient, you can think primarily of an infection. And then because those are pediatric patients, you want to make sure that they have received all of their vaccines. And you also want to look for systemic manifestations or lymphadenopathy, as those could clue you for autoimmune disease. And then we later heard that this patient had bullous lesions. And so in bullous lesions, there's a wide differential, but there are things that you must not forget, because those can have high morbidity and mortality. And they can include things like bullous pemphigoid and pemphigus vulgaris, as well as SGS and tumor toxic epidermolysis necrosis. And then you can also think of erythema multiforme and Staphylococcus caldenskin syndrome, which was mentioned actually at the beginning of the case and ended up being the diagnosis at the end. And then you also want to do a thorough medication review history for your patient, because this can also provide another clue towards the diagnosis. And also make sure to draw the time course with the patient's presentation itself. And so think about DRUS if a patient has been having the rash after 2 to 4 weeks after receiving a certain medication, typically an antibiotic or an anti-epileptic. And you can also think about SJS. And then make sure to do a neuro exam in pediatric patients, just to rule out, again, high morbidity mortality diseases, including meningitis and encephalitis that can manifest with a rash. And then for an infectious workup for this patient, we are thinking mainly about herpes labialis, HSV, HIV, especially with the systemic diffuse manifestation, measles and chickenpox, just because we weren't sure about their vaccination history. And always make sure to understand where the patient may come from, as those epidemiological clues may widen your differential. And then also don't just think about dermatologic diseases as diseases that have appeared first on the skin. They could be an internal disease that is now manifesting with dermatological manifestations. And so certain clues, like for example, LFT manifestation, may reflect an internal disease. Something like a high bilirubin may reflect hemolysis or a hepatobiliary disease. And then when it comes to the ALP, especially in pediatric patients, it can be borderline high, as those patients have metabolically active bones. But then if it's very high, you can think about bone diseases themselves or liver diseases, especially if the ALP is very high in contrast to the bilirubin elevation. And then finally, some teaching points on Staphylococcus caldenskin syndrome is that it mainly appears in pediatric patients below the age of 5 years, usually due to the exotoxin that causes epidermolysis. And it can manifest in the rash itself can manifest in the conjunctiva and the middle ear and the nasopharynx. And as we've seen in this case, it's usually generalized and tender and erythematous, and the Nikolsky sign is usually positive in these patients. And the rash seems to respond very well to antibiotics and resolve fairly well. And that's all for today's teaching points. Thanks, everyone.
Thanks so much, Ibrahim, for filling in, especially last minute too. Always appreciate you.
Yeah, also echo that. Wonderful, Ibrahim. That was you caught all the wonderful features. We were kind of like scatterbrained, but you put it all together so organized in an organized manner. Thank you, Andrew. Superb walkthrough of the case. I know it's difficult, but it took us to the limits of our knowledge. But I think I definitely learned a lot from Kashiar's case, and we'll be dwelling on it. So appreciate you, Kashiar, for bringing this case today, and also appreciate you, Andrew, for joining today and for discussing.
Yeah. See you next time, Ravi.
All right. Take care. See you. Bye.